thank you all for coming. We were trying to get some of the web broadcasts working. There's lots of requests on trying to see Jeff talk. If you haven't seen it, it'll be a lot of fun. By way of introduction, computational pathology, at least for my side, wouldn't have happened, but for Jeff being on campus and pushing us to do some fun things. Jeff, you were at Michigan Ann Arbor, then Ohio State,
undergraduate.
Cleveland Clinic,
Yeah.
Pitt, Fellowship in Pathology Informatics,
Yes.
And then Becky.
That's right.
Okay, take it away.
All right, thanks, Chakra. And thanks for letting me talk here. This is a subject that is near and dear to my heart, computer-assisted diagnosis for pathologists, pCAD. And I'd say it's theoretical, but it's not really theoretical anymore because we're starting to actually make it, we're willing it into existence, thanks to, I think this wouldn't happen without Chakra pushing me in return. This is a very great collaborative thing. And it's the sort of thing that I think can only happen in Pittsburgh. We have such a nexus of resources. I'm a pathologist. That's a doctor who diagnoses and looks at tests. I look at breast and gynecologic tissue samples, breast and gynecologic pathology, and I also, I don't know how formal it is, but we have a subdivision of advanced imaging and image analysis. And currently, I would say my main focus right now is on this, computer-assisted diagnosis and computational pathology. I guess it's one and the same. So I'm going to talk a little bit about the pCAD concept and some of the work because this predates before I'd ever heard of the term computational pathology and some of the pre stuff like BC, and then I'm going to talk about some of the stuff we've been doing after, especially with something called SPDX using spatial pathology. I'm going to speculate on the future. It'll be a treat, but it'll be an hour and a half, so that's a long talk. So I call it computer-assisted diagnosis for pathologists. I know that most of you think in terms of computer-aided diagnosis or computer-aided detection. These are radiology words or radiology terms. And I want to reiterate that radiology and pathology are very different. There are a lot of similarities, and there's a lot we can learn. But we're very different culturally, and we're very different in terms of our role in the healthcare system. So pathology is oftentimes considered like the bedrock. We're the final answer. And so by nature, we're very conservative about what we do diagnostically, because not only us, but our clients, our patients, our clinicians, if we say something in a report, they frequently believe that it's completely true, and they won't tolerate the levels of uncertainty that might be acceptable in other kinds of testing. So I think it's okay, and we're doing something different than at least what I see in the tumor boards with the CAD stuff. We're doing something different, so I use slightly different words. Words don't really mean that much, though, I guess. Whole slide images are scanned microscope slides. I imagine everybody here knows what those are. But these are basically large data sets. And they've been challenging, and we've only recently really begun to completely move past the engineering challenges. And we have regions of interest, ROIs. This is different from return on investment, which is, I don't know if anyone from the Steel Tower is listening, but so they would think of return on investment, which is important, but ROIs are roughly analogous to what we used to call fields of view when you're using a microscope. That's whatever you can see. You stop moving the slide and you look, and that's what you can see. And on the computer, it's like a glimpse of your case. And LIS, Laboratory Information System, this is part of the electronic health record, and this is what we use in pathology to manage our billing and a lot of the boring junk and a lot of the text data that we generate goes into this system, and this system sends and receives pathology data and other data with the rest of the hospital. Okay, so pCAD. So as I imagine this is an interactive and intelligent setup. And the idea is that it focuses the pathologist's attention on decisions that only they can make. So when I do my work, there are a million things I do every day that probably could or should be automated. So I started this out as like on the completely fantastical level, what if everything could be automated? And went there. Instead of just minor, what if we did this or that? I wanted the entire thing as automated as possible. So my background is I'm a pathologist, and these numbers get depressingly larger and larger, but I've been a faculty for about 10 years, and I sign out breast and gynae paths, so I'm I'm an expert at this, for better or worse. And before that, I spent 6 years of training, most of that in Cleveland. So I have a really good feel for where are the tough diagnoses, what are the really important clinical situations, and I stay up at night sometimes thinking about stuff like atypia, because it's in the eye of the beholder and it's very subjective. But this background gives me a really good background on the routine work pitfalls, counting, proofreading. I spend a lot of time on a breast core biopsy service, reading the slide labels, comparing them to the paperwork, comparing 2 different pages of the paperwork. One of them's filled out by radiology or the radiologist's computer. The other one's filled out by my accessioners, just making sure there's no errors. Because if I make an error, the wrong breast might be amputated, or I might miss a cancer because 2 patients got mixed. So we're always constantly doing a lot of these little silly things. I fold my paperwork in a certain way so that I can quickly flip between pages. This is a very old school workflow, but it's really highly optimized for microscopy. This is my microscope. I've included, these Mr. Quackers for scale. So this is a ceramic coated stage. It's like low friction. And this shiny crap is the steel that I've exposed by polishing it by hand. I've probably looked at 100,000 to 200,000 slides, probably more than that since I got here. And this isn't dirt, this is pitting and all sorts of stuff. So I've put in my time at the scope. And for all its faults, this is an extremely efficient workflow for a glass microscope slide. And I have a long background with the digital stuff, starting when I was a medical student, hanging out in the laboratory, playing around with lab systems, and as they started to show up, telepathology. I led the first pathology image analysis implementation at UPMC. We did it for breast marker, just one breast marker. And it ran for about 5 years, and then we pulled the plug on it. The complex decision, a lot of factors. Learned a lot. I was involved with a big UPMC commercialization effort in pathology for a long time. Learned an awful lot through that too. And I would say, starting with Adrian Lee was my initial contact into the computational pathology world, and then probably 2014, started working with Chakra and Lands and friends, and getting into the computational pathology. The pCAD stuff probably dates back to 2009-ish when I started thinking, there's got to be a better way to do all this digital pathology stuff. This is an FDA approved or cleared, I'm not good with words, image analysis system. This is an immunostain for HER2, which is, I guess it's precision medicine, right? Because with this positive stain result, we can subclassify this patient as having a subtype of breast cancer, and we can predict that she will respond to a specific therapeutic agent. This is great, but I have to circle this manually, and I have to get to the slide manual. There's a lot of stuff. And one of the things that quickly occurred to me is I don't really need the computer to tell me this is positive. I can look at this for less than 1 second, and then it's positive. It's great. So the focus is coming from, I guess, maybe in research where you want a quantitative answer for an immunostain, but in clinical use, we need that sometimes, but we also need to have the whole workflow that gets us here and gets us out of Dodge fast. This isn't even a good image. This is a blurry image because I blew it up from a small screen grab that's like 10 years old. And I can still tell, I know, as a human, I don't worry about it being a bad image. This is a rich image, and this is breast cancer. So I get my laser gizmo. I apologize if I blind anybody. I'll be good. So this is an estrogen receptor stain. Yes?
Just to get a better idea of how you came to it's yes or it's no.
Oh, I'm sorry. So the HER2 stain, the immunostain process, we use a brown pigment called DAB. And so when it's brown, it's positive. And this particular antibody, the HER2 antibody, has a membranous staining pattern. And when you see this chicken wire-like pattern, it's positive. One of my old faculty, David Hicks, the breast pathologist, used to have this animated slide with a little chicken, and then the chicken would bounce off the chicken wire, and then the stain's positive. So when you see that chicken wire pattern, strong nuclear staining, not nuclear, membranous staining, and greater than 30% of the cells, and it's positive. This is the estrogen receptor stain, and you only need 1% of the nuclei staining positively to call this. But this is a complex region of interest because it includes, they're probably not totally innocent bystander because they're strongly ER positive, and that's not usually seen in benign breast tissue. But you have some relatively innocent bystander benign breast ducts, and then we have cancer. And as a pathologist, even on this immunostain, we wouldn't diagnose on these because the contrast isn't very good. But I can see this round shape and this round shape. So these are in situ cancer, ductal carcinoma in situ, DCIS. And then this stuff is invasive. And here's a measurement. So when you use the image analysis, you begin to think destructive thoughts like, why can't the computer see the cancer? Why can't the computer tell the difference between invasive cancer and in situ cancer and benign ducts? And why do I have to manually circle the tumor, which in this case would take a long time? Why can't the computer find this? And then also, by the way, tell me, I think this looks about a millimeter in size, and let me okay that, rubber stamp that decision if I agreed with it. Because what if this is a real case? This is an inside joke. This is an incompletely de-identified picture of one of my colleagues at McGee, and he got this case consisting of about 200 slides. And he spent at least a half hour moping around the department. I can't believe this happened to me. I have to look at this case. This is a really big pathology case. This is like, I've only seen this like a couple of times. Usually, the cases, breast cases are like maybe like 20 to 50 slides, and occasionally you get like 100 slides. There's a lot of work. And in a case of this size, often you probably have just a few slides that are interesting. So if you had an in situ resection case, and all you had was this 1 millimeter of invasive cancer, wouldn't it just be helpful as heck to have, I'm trying not to swear, to have the computer find it and show it to you before you beat your head against a rock? A case of this size probably takes at least 2.5 or 3 hours to look at. That's a lot of time. And what if the interesting focus is at the end of the case when your brain is mush, as opposed to in the beginning when you're still sharp and not hating yourself? Not hating yourself, but hating life for giving you this tough case. So, what would help? Because I've kind of dissed on image analysis, and it doesn't help in a lot of things. So, diagnostic support would be great. The computer telling me, hey, this looks like cancer, this looks like atypia, kind of guiding me along those kind of lines. Manual labor, measuring, counting. I hate counting. I'm distractible. People are always phone calling, and boom, you got to start over unless you're like ticking on a piece of paper. But we do a lot of measuring for tumor staging. We do it for margins. Margins is basically the adequacy of the surgery. If there's tumor at the margin, then the surgeon probably left tumor behind in the patient. Counting. I can't believe like grown-ups are sitting in a room counting stuff. It's like Sesame Street, but we have to count things like mitoses and lymph nodes, tissue pieces. It never stops. And worse, I got to write the report. If I'm doing a telepathology consult from China, I usually write the notes on a Post-it note and stick it to my monitor. If I'm doing a UPMC case, I have a piece of paperwork that comes with the case, and I take notes on that. And then later, when I'm done putting the case together in my head, I dictate it into the computer, and this takes a lot of time. I mean, if you actually watched a pathologist, you would see they're probably only at the microscope actually looking at the slides 25% of the time. This is extremely labor intensive. And we spend a lot of time looking for inconsistencies or errors. I wish the computer would protect me against me or protect me against other people doing typos in my case. Triaging cases. What if there's an emergency case, but it's at the bottom of my stack? And I don't see it until 5:30 after everyone went home at night. That's a problem. I would like to know about that case as early in the day as possible. Maybe it's, I don't look at lungs, but what comes to mind would be like a lung biopsy with a fungal infection in it. That's an emergency case. You want to know about that. So it'd be nice if the computer could look at the cases as soon as it could and tell me, like maybe bump cases to the front of the line. And then also help with rare event detection, because I'm good and I like looking for things like a puzzle, but it's slow. It takes a long time to look for tumor in a lymph node, and you can always miss stuff. And I wrote up a lot of this stuff about 1.5 years ago in an article called 21st Century Workflow Proposal. So whole slide images versus microscope slides. So The current diagnostic work is pretty good for glass. We're pretty quick. And I forgot to play it. Will it break it if I back it up?
No.
Okay. I'm going to back up because we actually went through trouble to get this to work, and I forgot about it. So listen to this and try not to hear the mouth breathing, and I always hate listening to myself recorded. This is a recording. Of me. Yeah, that's Mr. Quackers, but he's going to... Am I doing it right, Barack? I have it on my phone if we can't.
No.
Here we go. Okay. I'll talk about this more later, but we actually been studying how quick, and can you guys hear that? Every is me going to a new field of view or region of interest. It's real fast. And you can hear me changing, and that's it. And I'm done with the slide. That's 20 seconds for that microscope slide. So it's real quick. Oops. Never mind. That's my fault. What is that PEBCAC, right? Problem exists between chair and keyboard, except that I'm standing. Okay. So glass is really quick. And if we want to do things with digital, we have to really pay for that by being even quicker or better, which would be something like computer-assisted diagnosis. So, but the thing is with the microscope, you have to look at the slides one at a time and in order. But the beauty with whole slide images is that they're a persistent digital data set. This is what my old mentor, John Gilbertson, used to say. You can do things to a whole slide image that would break a slide. You can chop it up and fold it and bend it and do all sorts of stuff with it. Rotate it. You can look at them side by side, simultaneously, one on top of the other. There's a ton of things you can do with it. And if we just treat them like glass microscope slides, it's a huge lost opportunity, because I'm firmly convinced that, except for a few niche areas, it's a complete waste of time to scan slides with the intent of Google Maps, click and drag around and look at the images manually. That's really a waste of time. So how do we automate these things? In my mind, we focus on what are the concrete work tasks. And we look.
Can you explain why it's a waste of time? Because it sounds like it's exactly the same thing you're doing with the glass. You put it on and you look around just like Google Maps, and then you have to take it off.
That's why. So the recording, I looked at a microscope slide in 20 seconds. Fast. Yeah. The optical quality it's analog, but it's much better than any camera that I've seen. It's quick. There's no scanning step. I don't have to spend $250,000 on a scanning robot or millions of dollars on a fleet of scanning robots and storage infrastructure. Even when you scan the images at 20x, which is not as high as we would normally use a diagnostic material, they're still gigapixel images. So they're expensive to store, they're expensive to acquire. There may be very good reasons to do this, but just looking at the slides in the Google Maps sort of thing isn't one of them, because I've never seen a whole slide image scheme that's as fast as the glass. Now, I have a daughter who was a teen in the pre-smartphone era, and I could watch her send text messages, and she could type really fast with a really bad keyboard. So I was thinking, if you gave somebody a digital imaging, like an old school whole slide imaging system, and you made them look at 50,000 cases, they'd get really fast on it. But why bother when you can just use the glass and it's much faster, unless you're doing something different than the glass? So it doesn't pay to do the exact same thing with the glass. You want to do something completely different if you can, because that's when you'll see the huge return on investment. Now, there are exceptions. Stat consults, sending stuff, there are exceptions to this, but I think for routine diagnostic work, non-telepathology situations, you need to have something different. Okay. And I'm firmly convinced that we're going to develop things. Some people use the word analytics. I'm not good with words. Analytics. We could even think of them as biomarkers, but they may not be biomarkers. They may just be features in the case or the tissue that the computer can pick out and analyze and find that we can't do manually. I'll talk a little bit about that too. All right, so I'm going to go through an example of lymph nodes. I'm going to keep track of the time. Lymph nodes are a great example because most pathologists have to deal with them. It's almost like a universal language. If you do any kind of a specialty where you're looking at tumors or doing tumor staging, eventually you're going to have to do lymph nodes, because tumors like to spread via the lymphatics and the lymph node systems. And currently what you do is you crawl through these lymph node slides, you're going slowly because you're looking for rare events. Usually they're negative, although it varies by tumor and site. I occasionally get like a lymph node that's clearly positive, but most of the time it's not, and you have to count lymph nodes. And in the future, you know, again, I would like the computer to read, so the gross description, the gross is typically free text data that's in the laboratory information system. It describes what's in the slide. So the computer, I would like the computer to have situational awareness to know, okay, this slide contains 5 lymph nodes or 5 pieces of one lymph node. I find this out by manually reading the gross description. So I would like the computer to be able to read the gross description, and the computer could look at all of the lymph node slides, not worrying about individual images or slides or anything, but just present me with ROIs that are triaged from most likely to be tumor to least likely to be tumor. And then as a result of that interactive experience, the computer writes my pathology report for me, including the counting and measuring. So this is a glass microscope slide, cartoon of one. And this has 2 cuts. So the way path slides, does everyone understand how pathology slides are made? Actually, we have a YouTube audience to consider. So tissue is shaved off of something called the tissue block that's wax, tissue embedded in wax. And usually the first cut goes closer to the label. Well, it will maybe vary from lab to lab. And then the deeper, like if you're going to do 2 cuts, then the second one's deeper because you've already shaved the surface off. The deeper one will go further on down the slide. And I've seen everything from 1 cut per slide to 20 or more cuts per slide. Some labs just go crazy. They'll run cuts all the way up under the label, and it's maddening. But in this case, if I'm looking, let's say these are lymph node fragments, I start here and look at this one. Now, in glass, you want to be careful not to miss things. So in glass, actually I'll probably start here. Start here, and here, and here, and here, and kind of go in a certain pattern. So other people will treat it like mowing the lawn, and they'll go like this all the way through the slide. And some of them are fast and some are slow. I tend to be quick, short, jerky movements. There are people who almost do a continuous motion kind of a drive. But the point is while I'm looking at this piece of tissue, I don't know if this is coming up on YouTube or not, but the upper left-hand corner tissue, I'm the world's expert on that patient's cancer and on her lymph node and on that piece of tissue. And it would actually make more sense to go to that lymph node because it's almost the exact same tissue piece. It's basically just a slightly deeper cut. And you can't do that with glass because if you're jumping back and forth in the glass, you're going to get lost. You're not going to look at the whole slide, and you're going to make mistakes, and you're going to get sued, and your life will be ruined. But if you scan the slide, you can see how old this is. I try to sneak in and update the years, but I clearly missed this one. That's, well, that would be 2 years ago because that's like a really large number. But in this case, once you've scanned the slide, it would be nice if the computer were capable of recognizing cuts. And once you recognize cuts, you can organize them by stacking them on top of each other. And I'm not exactly sure in a clinical workflow how would be the best way to look at 2 things simultaneously. I like the radiology thing where you use the mouse roller and you can scroll through somebody's noggin or their head scan. I would like to be able to do something like that with levels in path. And that would include even immunostains, or maybe side by side. But the point is you can stack the levels in computer land. And you can go further than that because here we have 5 fragments. So why not have 5 separate objects? So in this case, instead of manually driving around, I could actually have 5 separate logical things. And in this case, this is kind of the neat thing because now I have a row of lymph node fragments, and I don't need to worry about what slide they came from. They're just sort of arbitrarily, I think I put them from biggest looking to smallest looking. The idea is I'm decoupling my pathology work from the underlying medium, which is glass microscope slide. By scanning it and then by having the computer keep track of where I am logically, I don't need to worry about what slide things are from. Probably 99% of the time I wouldn't have to worry about that. And then and some of this stuff is really obsolete now that I'm working with computational biologists, computational pathology. We have different ways to accomplish this. But before that, I was trying to think, how would I break up that object? Because instead of manually driving around it, I think it would be faster to break it up into ROIs. So in this case, a breast cancer axillary lymph node situation usually you have fat, because that's in the axilla, in the armpit, and then you have the lymph node, interior, and then you have this little space called the subcapsular sinus. And usually when you get really small tumor metastases, that's the high yield spot to look. That seems to be where they embolize. So imagine if you could do the ROIs. And these days we would do the ROI segmentation automatically using our pipelines. But this is, I was thinking, well, what if the computer could recognize these anatomic spaces and divide the lymph node up accordingly? Then the last step would be triaging those images in order. It says the little red dot here, which indicates that has a little tumor there. So if it worked, the first thing it shows you would be the tumor, and the last thing would be all that benign fat, which I can usually look at the lowest magnification just really quickly. I don't even stop the slide sometimes because I can see it that easily. And if there were tumor there, it would be really easy to see. So in my perfect world, I would like to actually, do I have to really look at all this stuff? Once I've pronounced that the lymph node, I've looked at the riskiest areas, and I've decided that it's positive, or even that if I've decided that it's negative, I think in the future we won't look at the entire lymph node. And that's not crazy talk because we already do that with cervical cancer screening and Pap tests. Imaged Pap tests, the vast majority of them are looked at by a cytotechnologist, we okay? And an interactive computer system, and they look at about 20% of the area of the slide. And if the human thinks that it's negative, then it gets signed out, and nobody looks at the rest of the slide, usually. But a half hour in. Okay, so this is a photo of the lymph nodes. Here's the fat. Here's the lymph node inside, the parenchyma. And here's the subcapsular sinus space. And sure enough, here's a little tiny bit of tumor. This is really easy to miss, which means when I look at these, I look at them slowly, not nearly as quickly as you heard me looking at that breast core biopsy. And you can imagine the computer chopping up things. Oh, and also the computer possibly like laying down a measurement. He's like, maybe show it to me. Does this look like cancer? Yes or no? And you click yes, or you say, yeah, it's cancer. And the computer notes that in the report. And then maybe the computer gives you a measurement and says, this looks like 294 microns. And I look at it and I go, that's a reasonable measurement. That's good. And that's kind of how the interactive session would play out. And again, these are highlighted in orange because if it worked, these have cancer in them, so those would be the first things the system would show you. If you had a benign lymph node, this would be the first thing it would show you because it's still the high-risk subcapsular area. And you have a bunch of this lower-risk stuff with the lowest risk area being benign fat. So show the regions of interest to the pathologist. The computer asking interactively, do you agree or disagree with the finding is this tumor, and automatically catalog, including counting and measurements, all that stuff going into the report automatically. So that's the example. And as I say, in the future, like in 20 or 30 or 40 years, hopefully we don't have to review every slide. Really?
20 years?
No, it's less than that. But it's less than that. But who knows? We're incredibly difficult. It's taken years to get whole site images to take off, partly because there's not a good enough use case. We'll see what happens. I think with something like a sentinel lymph node, that would be like mammography or something. We're going to have to look at the whole sentinel lymph node. But if we're in a situation where somebody already is known to have positive lymph nodes, and it's a follow-up resection of additional lymph nodes, the stakes are lower in terms of the consequences of a false negative. So that might turn out to be acceptable to not look at all the slides. Or that's not true. Look at all of every slide. And the precedent for that is the gross, right? When I have a total mastectomy specimen, I don't look at the entire specimen on the microscope. Not even a pathologist, but usually a highly skilled pathologist assistant does the gross examination and picks areas for sampling. We don't put the whole thing through. So right now we have this dogma that everything that does go through on a microscope slide has to be looked at in its entirety, mainly because we hold on to those slides for a long time, and people can come by later and look at the slides and review them. But I would like to see in the future that we didn't have to do that. And maybe not 20 years, maybe 5 years, who knows? Sometimes things just crumble like the Berlin Wall, right? So I used to think that we talk about driving the microscope, and I used to think about being chauffeured. My dream system would chauffeur me around the slide, but that's not going far enough. It's teleportation. Breast core biopsies at UPMC, we cut, well, at McGee, we cut 3 levels. Level 1 is a superficial one, then a little bit deeper into the tissue block, and then even deeper. So this gives us a pseudo three-dimensional look at the breast tissue, and this is pretty helpful. 3 is a good number. More than that, and it gets to be a burden to look at for easy cases. Less than that, and you don't have enough information for challenging cases. Now, what if your tissue findings are like down here, right? And you look at this, and you look at this, and it takes you this long to discover the area. So again, teleportation can take you directly to the difficult regions of interest where you can make a really good expert decision and move on. So if I look here and I look here and I go, wow, that looks atypical, and I feel confident in that decision, I can look at the rest of the case very quickly. Even more quickly if I can stack the levels and look at all 3 of these, if not simultaneously, in very quick order. So instead of jumping from this piece to this piece, after looking at, let's see, if I go from here to here to here and now to here, I can jump around a lot better in digital land. And one of the pitfalls of glass, of course, is depending on how I choose to drive. So if I hit this core and I follow it like a road, and then I go to this core, I might miss that piece. I might not even look at it because it's kind of tucked away there. The computer would protect me against myself. Yes?
So in cases like on the previous slide, you run into situations often where, say you have those yellow markers, right? And there's some interesting set of things on level 2, and there's a different interesting set of things on level 3.
Mm-hmm.
You run into cases where looking at one before the other is going to make you think differently about the case and come to a different conclusion.
No, probably not. I guess yes, maybe. So if I look at 1 and I see something that makes me feel scared and iffy, and then when I get to 2 it looks okay. If I had looked at 2 first and I think, wow, that's okay, and then I see something iffy in 1, then I might not even experience that doubt. So sometimes. But for the most part, you're looking at the 3 of them as an aggregate. And occasionally you will run into something that you didn't see before, or occasionally you'll see something and it'll go away. So in that sense, let's say I run into something on the first slide that's located here. I still have to finish that slide before I go to the next slide. To do anything else is a little bit reckless. I think if it were compelling enough, I would do it. But I run a risk of not actually looking at it because there's no way to make sure that I went and looked at the slide except to have the discipline to make sure that I always finish the slide before I go on to the next one. And once I finish slides, I can jump back and forth at will. But I got to make sure that I looked at all of every slide. Because things like atypia by their very nature are focal. Yes?
So I'm a little bit confused as to how much information you were hoping for a computer to give to a pathologist. Because you mentioned previously you were hoping, for example, a computer would, give, here's the region of interest, here's the length of it, is this an acceptable way, versus in your teleportation slide, it's literally, here's some region of interest, why don't you go take a look at it? So how much...
It depends. So it's the work. You have to know what the work is. So as I think about it, pCAD has 3 components. And I renumbered them because I want to talk about the advanced machine vision, machine learning stuff last. It's there's work that you have to do. So for a lymph node, tumor staging lymph node, your main task is to find tumor. That's your big task. And if you find tumor, you have follow-up tasks. Measure it and count. So I want the computer to tell me not where to look. I want it to take and show it to me. I don't want it, it's like going to IKEA. I have a desk that I want, but now I have to go to their warehouse and find the desk and look for it. I want it brought to me, and it brings it to me. And it's part of that bringing it to me, if that's part of the work. I want measurements. I want the whole thing kind of delivered to me on a silver platter. Does that help?
Sort of.
So it varies by test. So there may be other, like if it's a fallopian tube, so a woman wants to be sterilized, so she has her fallopian tubes ligated. And the specimen for that is a segment of fallopian tube tissue. And in that, my main job is to identify the tissue as fallopian tube and to positively identify a complete cross-section, meaning I have proof that they transected the fallopian tube. That's it for the most part. And if I don't find that, that's an emergency phone call because that's a very expensive medical legal situation if somebody thinks that they've been sterilized and then they have more kids. So it will vary by the specimen. So some specimens are going to be all about finding that focus and showing you, look here. But once you're looking there, if you do think that there's cancer there, I want the computer to also provide measurement suggestions.
So sort of then a follow-up, would you then be okay with something like, in your example when you're talking about the fallopian tube, would you be okay with a computer essentially saying, with 99% certainty, this is a cross-section of a fallopian tube, and as a result, we think you don't need to necessarily take a look at it?
Maybe, although how long does it take to look at a fallopian tube? I would be okay if I could look at it in less than a second. But you're right, maybe in the future, I don't need to. If you think about automated hematology, the vast majority of complete blood count with differential are done in a completely automated fashion. And nobody even there's never even a slide that exists. It's just a tube of blood that the robot puts in the machine does its thing, and then the tube of blood maybe goes off and another robot throws it in the trash when everything's done eventually. So I would be completely okay with that if it were a validated system, if it were an acceptable way to practice medicine, if that were acceptable to the gynecologists, if that were the sort of thing that you could show was safe to do, then I would be okay with that, of course. But I think you don't go there right away. But eventually, yeah, I think that might be where it would go. So other things here on this slide. So we have to have and I use the word concrete. So when I was a resident, we used to have these things, we used to have these retreats, and we would get together and we'd brainstorm and we'd ask for things. We want a pony. We want ponies. We want to have our own computers to work on. And then the program director would be like, that's not actionable. We can't get everybody ponies. That's just not going to happen. You have to give us actionable things that we can actually do or tell us how to do it. And similarly, if as a pathologist I say, I just want this automated, that's not actionable because there's nobody in the world that can read the pathologist's mind and come up with the correct work tasks. Like, the clinicians may know what they want. So actually that's true. The clinicians may say, look, all you got to do is this and that. Sign it out as is. And as a pathologist, I may know, well, a fallopian tube, it's vanishingly rare, but I should also look and make sure I don't see cancer in the corner of it, right? Because really rarely maybe you'll see a cancer or something. So the pathologists are the experts, and we know collectively, like as a specialty, we know what we're supposed to do with a specimen. So any kind of a computer-assisted diagnosis thing needs to be kind of, the work tasks need to be spelled out in concrete, actionable fashion by pathologists. And this is complex and a lot of work, but it's already been done before with the gross. Remember I mentioned that a lot of the grossing isn't done by pathologists anymore. It's done by, we delegate that to pathologist assistants. And to facilitate that, every practice has something called a grossing manual, which is a huge book of specimens and policies, so that when the pathologist assistant receives a total mastectomy that's thought to be benign, sometimes people have a high genetic risk and they have prophylactic mastectomies. There's a protocol for how you handle that. You examine it, you make sure you don't see tumors, and then these are the microscopic sections you submit. And this would be a similar kind of a concept with trying to delegate this stuff to a computer system. So you would have the tasks, the exact tasks. I want the measurement with the size, I want the count of lymph nodes. Whereas if it's, I actually don't think we should count sentinel lymph nodes because usually it's just one lymph node, but these things would vary by lab. What do you want the computer to do? Not vary by lab. They currently vary by lab. I think in this kind of a situation, they would vary a lot less because this would lead to standardization. Total integration with the APLIS. So I've been talking about that. So I'm going to cover that later, yeah. So, and then lastly, the machine vision. So this is from that article I wrote. This is sort of a high-level flow chart. And this talks about, I'll make sure I'm kind of staying roughly within time. So APLIS, Laboratory Information System. So the computer has to have situational awareness. So that every whole side image it has, it knows what's supposed to be in there. And what's the word? Anthropomorphic. I can't say that word.
Yeah. You got it.
I'm giving it human qualities it doesn't have. At least not yet. But the idea is the computer has situational awareness and has access to the same information I would have. And that might include for a breast core biopsy, maybe being able to look up the radiology and see what kind of calcs we're looking at, calcifications or whatever. But the idea is the computer uses assimilated LIS data and it reviews the whole site images. It identifies the regions of interest for the work tasks that we need to do for the specimen, and then it goes over with the pathologist. The pathologist makes executive decisions, expert diagnostic decisions, and they have an interactive review of the ROIs. And as a result of that session, the computer creates pathology report data or a result, which the pathologist looks at or reviews or okays or finalizes, and then it goes out into the world. And again, I've talked about this a little bit. And we actually, so we put together something, I think maybe it'll be in the next slide, but basically go through, and this I think, okay, the pathologist has like a verbal interface with the computer, and the pathologist can talk to the computer. You know, think of something like a Microsoft Connect, and it can tell when you're facing it, right? If you're talking and you're looking into the computer, you're probably addressing the computer, and if you're not facing the computer, then the computer might ignore you. And if I say the right words right now, my phone will say, you know, Siri will fire up. But the idea is some sort of an advanced workflow that automates stuff. So we wanted to imagine this, and I've already talked about this. What images triaged how, right? Breast needle core biopsy is usually part of a system. Breast cancer screening system, which includes mammography, it includes sometimes palpated lesions that the patient discovers or that the doctor discovers. But there's a biopsy gets performed because there's a suspicion. And what we do is we're triaging the patient in the setting of that cancer screening machine, if you will, that program. And we're expected to call it benign or malignant or something else. In tumor staging, lymph nodes are a different story. We're basically looking for the tumor. These are very different tasks. And then fallopian tube I talked about. Very different tasks, depends on what the specimen is. But 99% of the things I look at could be pigeonholed into some sort of thing. This again, and we have like different procedures in different situations. So a mastectomy in somebody who's high risk, so it's a prophylactic mastectomy. Or a re-excision in a patient who's known to have breast cancer and a previous surgery, they thought they left tumor behind, so they're re-operating to take out any remaining tumor. So almost everything could be boiled down into something. And that really facilitates figuring out what are the right questions to ask of the computer, of the tissue. Have the computer ask the tissue, I guess. So, and again, diagnosis, grading and staging work, you know, often measurements or making judgments on the atypia that you see, the level of atypia. Adequacy, you know, are the margins free of tumors? Is the tumor completely excised? Assembling the report, this is a lot of work for some of the cases. There's just a lot of information. And sometimes you get, especially with breast, you get bilateral cancers or bilateral disease, and you really have to assemble a whale of a report that just lines everything up. And the whole time you have to be super careful to not mix up right and left. And other people do it, and sometimes you have to deal with the other mix-up. I had a case where it came in labeled as left, and then before, after they sent the case to me, but before, after they sent the case to me, they changed their mind, and it was a right, not a left. So I signed out my case as left, and I had to change mine from left to right. And then the person after me had a specimen, and they had to change it. So, you know, you spend a lot of time assembling reports and looking for errors. And of course, then we have the ancillary testing. So, you know, the HER2 stain I showed you, or estrogen receptor stain, trying to decide if the tumor will respond to hormonal therapy, or a combination of all the markers, which you can read between the lines and try to decide, is this tumor a so-called luminal A tumor, which would be expected to have a relatively good prognosis, but to not really respond that well to cytotoxic chemotherapy. So there's a lot of ancillary testing we do. And I would say there's future testing. Analytics, which is where the computer finds mysterious patterns in the tissue that the human can't quite see, and can maybe give us a prognosis. This is atypical, but we can ignore it because it's low-risk atypia. Or maybe we can get into things like tumor heterogeneity. We currently lack the informatics tools, vocabulary, the ability to talk about these sort of things, spatial biomarkers. We lack the ability to talk about these things in our current pathology workflow. And even if we occasionally will talk about things like this tumor looks like it has multiple different morphologies, it's not actionable because the clinicians really have no way to act on that unless we tell them, oh, half the tumor is HER2 positive. You know, it's really very limited what we can do. So this is Naveed Farhani, he's our fellow. And this is a testament. See that big smile? So he works for a startup in San Francisco now. And once the trainee graduates, it's really hard. He would say it was really hard to get me to finish the paper, and I said it was hard to get him to finish the paper. But we got it finished, and it's accepted. And we made a mock-up. So if you've ever done human-computer interaction design work, prototyping is important. And prototyping can involve stuff like pieces of paper, or you can draw it out. And the idea is you try to construct something that might look like what you're trying to visualize, what you're trying to achieve, and see how well it works. And we constructed a pCAD mock-up using PowerPoint, which is really crude, but it actually was kind of neat to sort of see what it might look like. And the PowerPoint is on my faculty website, my PIT one. I have a PIT and a UPMC because I have like a dual employment, PIT and UPMC. But on my PIT faculty webpage, the actual PowerPoint is there if you're at all curious. And we wrote that up and presented that. This is some excerpts. You see the transition where the slide came in. So Naveed's fancier than I am. But the idea is he put together a dashboard. And this is his interpretation of pCAD. But it's kind of neat. You know, it has, everything's kind of hyperlinked stuff. And it looks like he has things integrated here. So, you know, you would have access to radiology data, molecular data, and here's a checklist of work that you're supposed to do. And here's, you know, the images, I guess, the ROIs. And one of this is a little bit slow, but the idea is, and it's wordy too. I want my computer would be terse. You know, it'd be like, hey, meat bag, look at this. Is this cancer or what? You know, this is too wordy, it takes too long. Show me ROI 1. Well, I want it to know what to show me. It should know already. But here's a mucinous breast cancer. And so looking at this, the computer might say, okay, this looks like a ductal cancer. Do you agree? Invasive ductal cancer. And if you were like, yeah, I agree, and then it would move on to the next task. Well, I guess I ran off the end, but it would run through that and it would write up a report at the end. So that's our concrete work task. So total integration of the APLS. So this is another project we did because we wanted to explore this. Structured data in pathology is a bit of a fad, I think. It comes and goes. Like every 8 or 10 years, people get excited and then it fades out because it's not worth the effort or trouble. So I did this project with resident Michelle Hain, and we basically wanted to, so when we do situational awareness for pCAD, the easiest way to get information out of the anatomic pathology system is to use structured data, I think. But the problem is the vast majority of the stuff that we have is free text. And natural language processing isn't a solved problem yet. So this is a mastectomy case, and I find these incredibly difficult to read. Like I find myself like struggling to read these. These are really hard to read. And I like synoptic style ones better where it's sort of like bullet points. The idea here is there's a breast, there's a tumor, there's a biopsy clip from a previous radiology biopsy, and they found a little lymph node, which is unusual but can happen. And here's the key thing. This is what we call a summary of cassettes. And this is an accounting of what is in each tissue block. So if the computer gets whole site image from 1A, then it knows, okay, lesion is there, so there should be tumor, there should be biopsy site changes, and there should be anterior resection margin. Now, how do we know it's anterior resection margin? We paint the outside of the specimen, and we actually write down what colors we use. And we tend to use the same ones every time. So in this case, anterior at McGee Hospital is orange. So the computer knows to look for orange ink there. And if the computer's protecting me, if the computer finds green ink there, there's a problem, right? The cassette doesn't match what it's supposed to be.
This
So,
is a hypothetical. The computer doesn't actually do this today.
no, but it should.
Just making sure.
It should, and one step toward making it able to do that would be some sort of a structured data sheet. Because locked behind free text is we have this valuable, like, I guess, what's the word, itemization of what's in each slide or image. And then we have this further thing, what the colors are. This will vary from lab to lab and from specimen to specimen. And then here's part 2. This one doesn't even follow that, right? The summary of cassettes is in line with the main text, and it doesn't specify each one. It just says it's entirely submitted in these 2 cassettes. So it's hard. Hard for the human, hard for the pathologist. Now, I last spent a lot of time with XML in like 2003, 2004. I'm aware of since then that there are other things like JSON. There are other ways to structure data, and there are pros and cons relative to XML. But I already kind of knew XML. I'm not a structured data enthusiast anymore, so this is probably pretty poorly designed. But the point is we all know if you've spent any time at all playing with web stuff, that you can take something that looks like this and using something like cascading style sheets or some other sort of a World Wide Web based technology, you can make it look like however you want. So why are we persisting? You know, one of the things is we don't really need to have free text anymore. We should probably try to move toward structured data, because then the computer will have an easier time reading our LIS stuff and having situational awareness, right? So this is what this project was about, and I think it's beyond the scope of the talk, but when you do this, not only can the machine read the LIS, but it can also write the report for you in structured data. It makes sense to leave it structured. The computer says, okay, I see cancer, and then the computer puts cancer into the report. And if it uses a structured report, then you can get into really cool things. We have specially designed reports that keep the audience in mind. So the patient gets not dumbed down, but they get a lot of extra didactic or educational links associated with the report. The oncology team will get a different kind of report. Surgeon basically just wants to know if they're done operating or not. They don't really want all the details necessarily. And the primary care physicians get freaked out because they feel like they're on the sidelines, but they're still there because in most cases, the cancer patient survives the initial barrage of therapy and becomes a cancer survivor, and then has to resume her previous primary care treatment for whatever it is, hypertension or just seeing a doctor every year. Okay, now the cool stuff. Advanced machine vision and machine learning. I know, I sort of probably could have worded that better. So, you know, what do you call this? Artificial intelligence or machine vision, or the Terminator, right, for cancer. And because unlike the human, the computer doesn't, it's not that it doesn't feel pity or remorse, but it can look at those 200 slides and it doesn't get tired. It just needs time, but it will look at all of them for you, and it won't get tired like the human will. So there are definitely some great things here. And computational pathology is a term that I really didn't start using at the beginning of this process. But collaboration with computational biologists, people with good computer science backgrounds, machine vision, machine learning, this was really a missing link for me. Because previously I would just call it science fiction like advanced image analysis. And this stuff exists now. We're doing this stuff. It's really cool. So I've got I was going to put more slides and more pictures, but the talk's already too long. And you know everybody here. Chakra, and I'd say Chakra, you're probably, I would call you the ringleader of this stuff. And Lance Taylor you've been incredible mentors to me. I'm learning a lot about the imaging side of things and strategic things and how to put this together in a way that actually might succeed clinically. And we're working with some great trainees. Barak Tosin is a postdoc in Chakra's lab, and thank you. He set up, if you're listening to this over the internet, he set that up. And he has a tremendous background in computational pathology, having graduated from CMU, and he's spent time working on stuff like colorectal carcinoma and mesothelioma. And we have graduate students. Luang Nguyen is going to graduate this spring, we hope, and she's done an incredible amount of work. And young Dan Spagnola is in the back, yeah, and he's done some great work too. So this has been really fruitful, really awesome collaboration. And this is just sort of a one-slide thing that kind of talks about, but you know, so we have these, we call them computational pathology pipelines, and I like that term so much better than image analysis, because when I hear image analysis, I think about clinical systems that don't work very well and they're labor intensive. But when I hear computational pathology pipeline, I get hopeful again, because this is kind of an end-to-end thing in terms of the machine vision part. It has to be in the context of the workflow so that you can get your work done, but for the computer being able to, let's say, can the computer see cancer? Can the computer make decisions like there's a 99.5% chance that this is that, based on, you know, these are things that the machine vision can begin to help us with. And they can look at entire whole slide images, which is great, which means I don't have to sit there and as a pre-processing step manually circle things. And we have all these steps we normalize because every single lab varies. McGee Women's Hospital pathology slides look different from UPMC Presbyterian Hospital slides. This is true. And we need to be able to do sophisticated analysis of these slides. We need to take into account some of the variations in the staining color. And we have these steps we go through to find and segment the image logically into structures, And then we can do discriminative spatial statistics. I can actually say the words. The idea is we use spatial statistics, the spatial context of the structures and how the structures are organized, and we can use that to begin to make computerized judgments about ROIs. This is really cool. These three organizations, Carnegie Mellon Center for Machine Learning and Health, University of Pittsburgh Center for Commercial Applications of Healthcare Data, and UPMC Enterprises. So these three organizations got together and formed the Pittsburgh Health Data Alliance, which is a really big initiative. And our group, our project, was one of the first six, but maybe one of the first three projects that actually funded. And we did great. We did a pilot project for them. We were formerly called CompPath, now we're calling it SPDX, Spatial Pathology Powers Cancer Diagnostics. So it's spatial pathology, spatial statistics. And it's really cool. We wanted to do sort of a quick project, but something that might be high impact. So we thought about atypical ductal hyperplasia of breast. Breast core biopsies are mechanically very simple specimens. There's no huge gross description. It's usually a few pieces of tissue that go into a tissue block, and you cut levels and you look at them. They're really, really quick specimens. I played that slide where I looked at a slide in 20 seconds, and sometimes it's faster and sometimes it's slower, but they're very, very fast cases. There are huge diagnostic dilemmas to be had, though. They're not simple cases in terms of the diagnoses. So we have this entity called atypical ductal hyperplasia of breast. And there can be significant controversy and disagreement between pathologists, sometimes even within a pathologist. You may call it something different on day 1 versus day 2. Almost all breast cores are easy. Most of them seem to be easy, but there's this area in between. So a lot of them are clearly malignant, a lot of them are clearly benign, but then you get things that are atypical and maybe malignant, atypical, maybe benign, and these are really hard. There was a study, a very controversial study published. It's a seriously flawed study. They took liberties, maybe too many liberties, but this group reported large discrepancies between pathologists, maybe non-specialists agreeing only, depending on how you read the numbers, like 50 to 70% of the time. If you have consensus or if you use experts, the agreement is much higher. But the point is, if you're in Uniontown, or if you're in rural Eastern Oregon and you go and get a biopsy, your pathologist, whoever sees your biopsy, may not be nearly as comfortable looking at breast tissue or atypia as somebody who's at a major medical center, because it's not that common. This is a really soft number, 1.6 million biopsies per year, and it includes non-core biopsies. But the idea is there are a lot of breast biopsies a year, and at least 1 million of them are benign, and at least 10% of those are thought to be atypical. And so this is a decent sized number, at least 100,000 atypias in the United States. But when you break it down, if you're only looking at a few, like maybe 100 or 200 breast core biopsies a year because you have a small practice, you're probably only seeing true atypia about 4 or 5 times. If you have 100, right, it's like maybe 4%. And so you may not be well equipped to do a good diagnosis because you just don't see it that much. So keep track of the time. Just a half hour more. So if you have a breast core biopsy, benign is the easy approach. And malignant is often easy because these are usually straightforward. And you can sometimes experience some doubt, but for the most part, these aren't where the problem is. And malignant has a clinical pathway. If you diagnose cancer, then the patient goes through the therapy thing. They may have therapy before or after surgery. They have surgery, and then they're a cancer survivor, and that's a straightforward pathway. And for the rest of their life, they're a high-risk patient because they had cancer once. But then we have the uncertainty and the gray zone, and we have the atypical or high-risk specimens. And a lot of times you have to, if not you, but they, the radiologist will recommend a surgical consult, and the surgeon will feel compelled to operate on that patient, even though it's probably benign, because there may be an unacceptably high risk that there's currently cancer in that patient, but it wasn't represented in the biopsy. And this is a tricky zone. You want to minimize this. The medical oncologists I've spoken to are frustrated about this because the majority of the surgeries turn out to be retrospectively unnecessary and benign. Now, prospectively, they're completely necessary because there's no way to know which atypias harbor cancer currently. Currently, there's no.
Elaborate like a little bit on that. How do you get to this ground truth that it was low, if it wasn't high risk, it wasn't, it was atypical, but it was not malignant?
Well, you do a
How do you know that the malignant and the benign, do they follow up to see that was actually the right diagnosis?
Well, typically these patients are enrolled in breast cancer. So when you give somebody a malignant diagnosis, they're going to have surgery at some point, and there will be additional documentation.
Right. But how do you know that they didn't get more? The reason they didn't get more cancer is because they had the surgery versus, they didn't actually have cancer to begin with. Is there any way to know that for sure?
No, because, I mean, at some level, maybe, because there will be people who have a completely benign diagnosis who undergo surgery because the radiologist felt that the site was discordant and they thought there should still be something there. But that's not, most of the people who are benign are not operated on. Now they're followed, hopefully.
Benign or followed, so.
Right, because of the mammography, breast cancer screening. So typically they're not, it can happen, but usually they're not just lost to follow-up. Usually they continue to participate. Because one of the things that's different about radiology from pathology is radiology is strongest when you have a series of scans. Actually, that's not so different. It's the same, like let's say Pap tests and cervical cancer screening. 5 negative tests in a row is better than 1 negative test, but the radiologists are also looking for change for year to year. So they're followed. There are tumors that can completely confound the system. Invasive lobular tumors sometimes can grow very large, and retrospectively you may not even see anything, even if you're looking retrospectively on the mammograms. So you don't always know for sure, but it's generally been good enough and it works well enough in terms of how patients are followed up. And of course, they try to get better with the mammography. They do things like tomosynthesis and CAD, trying to improve the mammography detection for cancers. All right, and so if you have surgery and it's benign, you're still not out of the woods because if, let's say you have a breast core biopsy and it's atypical and you're cleared by surgery, now you're a high-risk person because there's a growing body of evidence that suggests if you have an atypical diagnosis, you have a much higher absolute risk of breast cancer. I think it's 30% was the number that sticks in my head from a paper I read last year. And so there's growing thought that these patients should be considered high risk. They should be offered hormonal therapy, even though they've never had cancer before. They might be offered additional screening, MRI screening instead of just the traditional mammography. And when you do extra screening, you're going to start finding extra things. So these patients are going to probably, as a group, have biopsies and surgeries that they might not have had they not been called atypical. So this decision begins to have lifelong implications to the patients. We thought this would be a very high impact thing to study. And of course, there's a small number of these folks that actually do harbor malignancy. They're upgraded.
Jeff, can you just, I normally hear about the atypia getting upgraded to malignancy, which is those percentages are really well known in the literature because you worry about that a lot. What's the percentage to go from atypia to benign on the surgical resection? Do you know?
It would be, I think it varies and it's hard to say, but when I was looking at this data, it seemed like it was about 95%. Probably it's lower than that, and it depends on how well you're detecting atypia. I think if you're doing a great job of detecting atypia, you'll actually have less risk because you're finding more stuff. It's right around like 5 to 10% risk of upgrading. It's kind of what I've been.
So there's a risk of upgrading that's going to be around 5% to malignancy. Because some of them will just come back atypical.
Right.
ADH.
Yeah.
So a fraction will be ADH, a fraction will be upgraded to malignancy, a fraction will be downgraded to benign.
Yeah.
How's the ADH versus benign from an atypia on a core biopsy?
I'm not entirely sure.
That's your key question, yeah. You want to basically demarcate those three groups, yeah?
Well, not necessarily. From the surgical standpoint, if you call it atypical and you do a surgery and it comes back atypical, that's the same as it coming back as benign from a management standpoint, because nothing can change the fact that they've already been called atypical. So they're already a high-risk person no matter what you find No, even if it's totally benign. So from the surgeon's standpoint, their interest ends with, did you find the biopsy site and is there cancer? So it doesn't make a lot of sense, you know, when you think about atypia, you think, well, wouldn't they care about finding more atypia, when in fact that's really not something that enters into at least the surgical equation. And so, you know, the atypias that come back atypia actually isn't that rare. I mean, I think it's probably, so if like 4 or 5% come back as cancer, I would say maybe from from going through these slides and seeing what I was seeing, it was probably 30%. It was actually not that rare. There was usually, it's probably higher than that. It's probably like 40%. It's really common to find atypia. Atypia on the biopsy, you'll often find atypia. On the other hand, if you don't find any atypia in the excision, you don't worry about it, because as long as you have the biopsy site and you're confident that the biopsy site was captured and that you're sampling the area, you're still accomplishing the mission, because they're not operating to remove the atypia, they're operating to make sure that there's not cancer there. And this changes with lobular neoplasia, because lobular carcinoma in situ isn't really treated like cancer most of the time, or DCIS. They don't excise it. They're treating it like an atypia where they're excising it. The risk is higher, but they're treating it more as a risk factor for a local issue. Does that answer it? And this is where I'm just a simple country doctor. Like from the practical standpoint, and it's easy to say it doesn't matter. It may matter, but from like a surgical standpoint, it really doesn't matter, because they're really just looking for cancer. Okay. So this was a small study, but we did it rapidly, and we looked at 46 ADH cases. And there were about 1,000 glass slides there, believe it or not. And we picked one slide per block, I picked. And we scanned them. And for ground truth data, we used the original pathology diagnosis. So these cases were diagnosed by a variety of pathologists du jour at McGee Women's Hospital. And I went with their diagnosis. Some of them were like really super, this is really great ADH, and some of them were less great, but we wanted to use, what was the clinical ground truth. And whenever you diagnose atypia, at least at McGee Hospital, you, if you're contemplating anything that's atypical or malignant, you show it to sec pathologist for a second opinion to verify. So there's this QA step. So you're not just a cowboy making calls and being trigger happy. When you call it, you really mean it, and you get somebody to agree with you. So this is the breast core biopsy. And even though they may look like perfect little, it's a needle, so it's like a core, it's a cylinder of tissue, but when you get it onto the slide, it's usually bent and there may be gaps in it.
So just the ground truth is a yes or no?
The ground truth in this case is atypical ductal hyperplasia.
So either yes or no?
I guess, yeah. Yeah.
Or like a gradient.
Yeah, I guess you're right. There's a gradient and there's a threshold. And sometimes you see something and you know in your bones it's atypical. And there's stuff that I know, but I'm saying maybe I do, right? And then there's stuff where you look at it and you go, God, that's really iffy. I don't like that. But I don't feel right about calling it atypical. So you show it to people. You experience doubt, because it's a continuum between something that's benign, or maybe like columnar cell change, which is a benign finding, and something that's you would actually want to call carcinoma. And there's often a gradient, and they're like flat epithelial atypia is probably like 3 different distinct entities that we just lump together. So there are a bunch of things here, and it's complex. And it's amazing that we got any results at all with only 46 cases. I thought that was really good. So first thing we do is we scan an image, and here's an ADH area. And the second thing we do, and these are big, so this is a 15,000 by 30,000 pixel image, even at 20x. And 20x is probably okay for 95% of the diagnostic work that I do. Now, if I were a transplant pathologist, I would get angry and say I need 40x for everything that I do. But the fact is the 40x lens doesn't get used that much on my scope. The second thing we would do would be stain normalization. This is really important because if you want to get consistent results, you want to have consistent looking pathology stain. And it varies by lab to lab for the most part. Now, most labs use stainer robots and well-established recipes. So within a laboratory, you may not see a large amount of variability, but you can see some, and you definitely will see it between, because hospitals are semi-independent political units, believe it or not. Even in a place like UPMC, McGee Women's Hospital's laboratory has its own history and its own procedures, and although sometimes things get standardized, a lot of times each hospital lab does its own thing. This is work Luong and the rest of us have, I think this one submitted. It's in review, medical image analysis. The next thing is spatial color statistics. And the idea behind this is to help us find and segment out the structures that we're interested in this case, the ducts. Because that's the name of the game of the breast is usually, you don't ignore the stroma, but the ducts are usually where the action is in the breast core. The stroma has a lot of action too, but with this project looking at ADH, we wanted to look at the ducts. And in this case, we have the ducts that are highlighted. And once we have that, then the next step would be triaging those ROIs based on those features that we extracted from the image of the ducts. And I say we, I understand a lot of this, but it's not as good as Chakra's understanding of this because my end is on the diagnostic end. But as I understand this, this is useful to me because the computer has the capability of putting things in order from most atypical to most bland or benign looking. That's a word I don't use much, but basically very normal looking or not likely to be cancer or anything. And so this is a great way to approach it. So in the future, the computer might be able to tell me this is definitely atypia, this is definitely cancer. But in this stage, this is nice to be able to do something that's non-judgmental, so the computer kind of triages it. And I look at it myself and I make my own judgment, but I have the understanding that the stuff that it's showing me first is going to be the most atypical stuff that's in the specimen. We've also, this is going to be in Melbourne this year. I was just in Melbourne last year, so that'll be good for Luong to present that. So we use the original ground truth data. We have the QA step. And the neat thing is ADH is usually a very focal situation. So you may find more in the excision, but a lot of times you don't. And even within the specimen that you have, you may not have a lot of ADH. So we had 100 whole slide images. The vast majority of those whole slide images actually contained just benign breast tissue, and there were just focal areas of ADH. And part of that is because the radiologists were targeting calcifications in a lot of the biopsies. The calcifications were separated or enriched in a certain part of the specimen. So certain slides were enriched and were way more likely to have atypia in them. And then a lot of the slides were kind of like extra tissue they had to take out. You know, they're just taking cores, and a lot of the cores didn't contain ADH. And the version 1 of our pipeline I was able to identify 72% of the case. 72% of the time, I was able to find atypia versus benign. And we've improved this. We tweak on it, and we work with there are public data sets, not a lot, not enough out there. I think Backslide has one. There are breast cancer data sets you can use to try to throw your pipeline at other things. And this is a very quick thing. I think one of the things we really need to work on is getting more images.
When I say 72%, is that 70% interest, 70% of patients?
That was 72% of cases, right?
I think in this case, regions of interest.
Regions of interest. Okay, then regions of interest.
So for a patient, you're probably doing better.
Yeah.
For patient, we're probably.
You only need one false positive to elevate them.
And keep in mind, this is not rubber. This is a robot system we don't trust yet. So if this were clinically being used, the pathologist is looking at it very carefully. And even if something is missed, it's unlikely that the pathologist would just let it go. So the idea behind this isn't yet a super automated setup. The idea behind this is it's an expedited or assisted review. So the pathologist is seeing most of the time the most atypical stuff first, so they make their decision quickly. Wrapping up. So now this is beyond I'm out of my element with regard to this, but deep learning is very popular right now. A lot of people are using deep learning. And Dr. Van der Lack in the Netherlands likes to say, deep learning is clearly the way forward. And there's this black box argument. One of the things is, when we're working with new technologies, it's good to know how they fail, and it's good to know what's going on. And one of the neat things about the approach we use with spatial statistics is we can see what we're doing, and we preserve the spatial relationships. And this is important because I think this allows us we can still do the machine learning and the assisted diagnosis on these, but we can see the spatial context, so we can kind of begin to learn what is a pathologist queuing in on. What is atypia? And like I said, I stay up at night thinking, what is atypia? And this also preserves the tumor microenvironment data. So this allows us to begin things that we currently don't have. I don't have like a mouth to articulate these things, and the clinicians don't have ears to hear them yet. But things like tumor heterogeneity, the tumor stromal and inflammatory biomarkers, right? Checkpoint inhibitors, this stuff is really starting to take off outside of the breast. It's only a matter of time, I think, until we really need to begin, or we get a lot of demand from our clinicians to start looking at these things, not just in breast cancers, but also in things like atypia. Analytics, right? So analytics would be not so much biomarkers, but patterns that only the computer can see in the biopsy tissue. So next steps. So the ADH pilot study, I think, was moderately, it was really successful. 72% isn't like a great number, but at the same time, I think that's a great start. And considering that it's a supervised process, the diagnosis thing would still be supervised, I think that's a great start. And it's already, like 80% when using, I guess, version 2 of the pipeline. And I think it will get better and better, especially as we have larger studies. ADH is a very niche, I never know if I'm saying that word right. It's a very niche thing. And to be really useful to people, I think we really need a pipeline set up that can accommodate any breast core biopsy. Because it doesn't help you if you have to get to atypia before you can use it. It's better to use it at the beginning and then to have the computer guide you. And some of the cases will be easy. Yeah, it's clearly cancer. But even that, if the computer is doing its triage review properly, I think it still speeds everything up. But we want to do larger study. I would like to do thousands of slides, actually, and scan as many things as we can. Maybe the entire output of McGee Women's Hospital of breast core biopsies for a period of time and get large sample studies. There are critical elements. Ground truth data collection is very important. And this can be semi-automated, but at some point, the people who are most useful for annotating are going to be the people that are most busy and hard to get. Busy working breast pathologists. You don't want to hire a general pathologist to annotate these things, and you don't want to get somebody who signs out 3 minutes a year. You really want somebody that's spending a lot of time and has a lot of ongoing experience with these things to do your annotation. This is really a difficult thing. And I think it's part of the reason why we have such a good advantage here at UPMC at Pitt to do this work, because we have this. We have a lot of people who are good at breast core biopsies and the validation techniques. What does it mean, like patients versus ROIs, or what does it mean if it's, does it matter if you're viewing all of the ROIs and it misses, let's say, 20% of the time it misclassifies, it's probably not all the way, putting it all the way at the back. These are practical things that will come out. They're emergent, like what's the actual real world accuracy of these things? So we need to study this stuff and expand it to, work with other institutions. And then also look at other solid tumors. If it works for breast, it should work for other things like colon or lung. So I'm wrapping up. This is Terry Jones. She's a medical student. And one of the things we do is, how do we justify this? So I know it in my bones. I know it. So I really feel strongly that when you do this sort of a thing with a computer-assisted diagnosis, that of course it will be much faster than the Google Maps click and drag on the screen, because I've seen both sort of approaches. And I hope that it's faster than looking under the microscope. But the microscope is very fast for breast cores. But I also know that, like a big tumor case, the microscope speed isn't as important because you have all this other work that you have to do. So we're studying this. So I played that sound. I don't know if I should play it again or not. It'll probably get tiresome. So, pathologist to do another 15 cases. It was 10 cases that we have usable results on. And then Terry listened to the audio tapes and basically recorded how long were the ROIs. And we want to ask questions like, so does the case review speed up when you make good decisions? So as I look at the case, I talk out loud. This, so we know, okay, this is this slide, this is that slide. This is when we made the decision in the case. So this has been accepted for presentation. Our preliminary results were that this was a 55% time savings, making assumptions that pCAD existed and that it worked, making assumptions that we could simultaneously view all 3 levels at the same time, but basically going through these I guess, simulations of pCAD, not actual working pCAD, but making assumptions about how it might work, we had a pretty good time savings. I thought that was really good because breast core biopsies are really fast. They're really fast specimens. We actually call the rotation Q1 for quicks because they're quick cases usually, even when they're hard. But the problem is they're still time consuming. Everything we do is time consuming. When you think about more than 1 million breast core biopsies every year, if you could wring out 55% more productivity, that's actually a pretty big number. All right, so again, good pCAD is teleportation. And the last thing I'm going to touch on, I think, is the markers thing. Once we solved the diagnosis piece, we were far from done because, like I said, we're currently pretty primitive. For breast cancer, we do 4 markers: estrogen and progesterone receptors, ERPR, HER2/neu, and Ki67. Ki67 is a proliferation marker. Now, if you do a very careful quantitative job with those immunostain markers, you can a lot of times approximate a lot of times predict what the oncotype DX score will be. And Rohit Bhargav and others at McGee Hospital put that together as the McGee score. You can actually go on the web and enter parameters such as these biomarkers, the size of the tumor, the Nottingham score, and it will give you a recurrence score. And another group led by one of my old faculty, Dr. David Hicks, he's a breast pathologist, and they modified the score a little bit, but this is like a $4,000 test for oncotype, and once you do that, that money leaves the health system forever. And they found that a subset of their tests, they could reliably predict that those tests would come back with low recurrence scores. So they might, using the McGee score, and I think this is what we're headed to, is trying to reduce the reliance on some of these expensive tests, especially if they don't provide more information than we're already getting. But the problem is this information is locked up, and we don't have good bioinformatics tools. So image analysis is clearly not enough. We need the spatial context and informatics tools that will allow us to report these features. And I'm not going to spend time on it, but I wanted to at least show a few screenshots from a paper that Dan put out. This came out in November, where we have, in this case, ERPR and HER2 biomarkers, multiplexed, fluorescent, and hit the space bar again. There we go. And so this is already kind of a, so each of these little fried egg shapes is a different immunophenotype. And you can get into things like looking at the tumor heterogeneity, and maybe certain populations travel together reliably, and maybe certain, and this one is really heterogeneous, and maybe certain populations don't like each other. I was recently in Europe at a computational pathology symposium, and there's this German guy, Dr. Jörg Ackermann from Frankfurt, and he gave a neat talk called "Nobody Likes a Chubby Peewee," and I thought it was a crazy talk at first, but what his talk was about was basically when he looked at Hodgkin lymphoma cases, there were certain cells that were afraid of the big Hodgkin cells. So this is something that I think will become a very big part of our practice in breast pathology, and it all requires computational pathology and computer-assisted diagnosis as a foundation. So in summary, things are happening very quickly. So we have a lot of the pieces already existing. Please, this is more for pathologists, please don't think that digital pathology begins and ends with the manual review of virtual slides. Virtual slides is obsolete terminology because it doesn't, well, I won't get into it, but the idea is manually looking at microscope slides on a screen is usually not the way to go. And we should plan in the future. If this pans out, pathologists used to spend less time signing out, and in the future we might spend less time signing out. And in a dystopian universe, maybe we'll just be handcuffed to the digital microscope. We'll be signing out more. But there are things that we do that are value added that we do less of when we have to sign out more. Education, a bigger role in multidisciplinary healthcare teams. Often we only form multidisciplinary healthcare teams at the frozen section desk or at the tumor board, but there's a big opportunity there. And I think computers will begin to enable new biomarkers, putting it in quotes, because that will also include just H&E based features too. Thank you. Yes?
Yeah, so when you show that form, that continuum of APPA,
Yeah.
the normal to the most linear, how much do you think that the patient's individual characteristics play into account? In other words, let's say, do you know what is considered to be atypical in a Caucasian versus an Asian person? And is that taken into account?
For the most part, when we review slides, we don't take that into account. Demographic, the patient's race, these things aren't necessarily super reliable anyway, because whoever's collecting the data may not be aware of how important it is in terms of, figuring out somebody's relative risk. It can be difficult to know that for sure and to feel confident in that if you were looking for that. There are different lesions that may have a higher risk. Younger patients will be more likely to have basal-like phenotype lesions or high-grade lesions. But that doesn't currently play a huge role, and that might be part of the thing where the computer, since it has good situational awareness, may be able to put together, because all that stuff is also in the LIS. So it's just another data field, and this might be part of a pattern projected on. It might be something that kind of emerges as we get better at using the computer to synthesize the data that we have in front of us. Yes?
So when you're classifying something as atypia, is it just something that the computer doesn't recognize as, say, a tumor or something that's benign?
So atypia is a defined entity. So the white tower, the ivory tower, the people that are the academics that create they tell us that if we follow their directions, it should be reproducible and easy to spot atypia. But the problem is when you go out in the real world, people often they'll use atypia for things that weren't necessarily it wasn't intended for. They'll use it in ways that weren't intended when somebody came up with, these are the criteria for atypia. So sometimes you'll get things that are called atypia that everyone would agree is risky and worrisome looking, but maybe doesn't fulfill the criteria of atypia. So by that standard, for the most part, if something's called atypia, that means it fulfills certain criteria or it lacks malignant criteria. And this can be difficult. This can be a difficult judgment when trying to decide between ductal carcinoma in situ, DCIS, and ADH, for example. So you may have something that's kind of ugly looking, but you don't want to call it DCIS, because when you do that, you convert the patient from a civilian into a cancer patient, and they may be liable to have things like radiation therapy and big surgeries. And if you're not confident in calling it a cancer, you may decide, okay, I'll call it atypia, and that gets the surgery to happen, and it gets the patient to the next step. And if there's really something there, they'll find it when they do the excision. And I think that's probably the mindset of the pathologist. So usually when something's atypia, it's because it is atypia. But occasionally when it's called atypia, it's actually something that's worse than atypia, but you can't prove it.
So like atypia would have to be also like class, or like the computer would also have to train on specific types of atypia in order, like.
The more cases, the better, because atypia is a diverse thing. Multiple different things. Apocrine, you can have solid atypias with micropapillary architecture. You can have really architecturally bland things with cytologic atypia that you would be really uncomfortable, just calling benign. It is diverse, so you want as many examples as possible to train on. Yes.
So one of the reasons it's so interesting is it seems like a field where lags very far behind like the state-of-the-art computational techniques. It's like UPS just this year started mapping up optimal routes for their drivers and saving hundreds of millions of dollars.
Yeah.
It seems like, you would have thought they'd done that earlier. A lot of things, it seems like you would have think this digital technology would be like the standard, and it isn't. And you can explain some of the reasons. But if I was the CIO of UPMC and I wanted to spend a ton of money in it, money was no object. I wanted to have the best possible, most modern digital pathology workflow instruments. What would that get me?
Well,
what is the commercial best digital pathology workflow tools?
so I think in the breast realm, we're starting to hit at it with looking at our efficiency studies. Pathologists are incredibly expensive. Not incredibly expensive. They're not as expensive as surgeons, but they're expensive. We're expensive, and you want to give them the best efficiency you can. And they're diminishing returns, but I would say if you could save 55% on, let's say, physician costs to get the diagnostic work done, that would be a big deal. There are softer targets, like what about the unnecessary surgeries? You probably can't go in and have breast surgery for less than $10,000 or $20,000. That's a lot of money, especially if that's a surgery that could have been entirely avoided based on analytics or based on a computer-guided diagnosis. There are other things.
I guess I'm asking, like, what's the commercially available system? Does it give me teleportation? Does it give me region of interest?
We're building it, but it doesn't exist.
Nothing like that exists.
Nothing like that exists at all.
So if you buy a digital pathology system, it is virtual slides.
Yeah, in virtual slides.
Is it at least a touch screen?
No.
Can I draw on it?
Yeah, sometimes, if you have permission. It's very variable. You can draw it with a marker too, but that's nihilism. But this has been frustrating, but I've learned so much from going through this experience in terms of, we had a commercial venture that didn't do well, and I think that was multifactorial, but one of the things that I wish that we had learned sooner would have been pushing for a computational thing. And this extends beyond just the images. When you think about, UPS, by optimizing their truck schedule saves money. The pathology lab, probably there's a lot of money to be saved in terms of optimizing stupid things like, I'm on service, I'm covering a breast service this week. And on Tuesday, I had 6 cases. And I usually would expect to get maybe 15 cases. So I had a really light day. Now, we knew on Saturday at 4:30 in the morning, the computer generated an email and sent it to me telling me how much work I had waiting for me on Tuesday. So there are a bunch of little tiny inefficiencies that exist in the system that we're not really exploiting yet. There's a lot of low-hanging fruit and fruit, frankly, that's sitting on the ground. And part of the reason this is very difficult to do, but obviously these would be stupid things like scheduling pathologists based on when there are cases, maybe moving pathologists around. These are maybe beyond the scope of this sort of a thing. But I think as you get into a more rigorous workflow, this would be one of the things you might see would be more control over pathology assets. And I imagine radiology's already been there. Radiologists schedule patients to biopsy so they have clinical time, and then there are radiologists that are locked inside a closet looking at dark screens until they're done without any bathroom breaks, probably because they have 10,000 chest x-rays to look at. These things I think come with optimization, but pathology has been firmly fixed in the 19th century microscope model with good reason. It's extremely efficient and cheap relative to other options, and we've only recently solved a lot of these engineering problems. Scanning slides is hard, and certain slides are resistant to scanning. Even with the best stuff you could purchase, you still have a hard time getting a good scan. So these are things that's one of the reasons we're so far behind. Yes?
The other question I have, going back to the other side, Dan's study, is that you're showing there's 3 markers, right, with 3 or 4 markers, and showing different heterogeneity.
Yeah.
Now, the underlying assumption that this actually has biological meaning. However, one could pose the question, how did you select those 3 markers to begin with, and why do you think it has any better predictive power than 3 other markers?
Well, those are markers that have emerged. I think certainly the ER and HER2 are easiest to justify because they have direct clinical pharmacological targets. And when you look at ER-PR and Ki-67, like with our McGee score deconstruction of oncotype, you realize that if you're really rigorous with how you do your stain scoring, you can extract far more information than you could when you just say, oh, it's positive or negative. You know, the vast majority of community practices for their ER and PR pretty much give a positive or negative score, and they'll say, oh, it's moderate or it's strong. But that's not a very quantitative statement. And so the vast majority of the time it hasn't really taken off yet. I would say, I don't know, maybe there are other markers, but I don't, you know, they haven't emerged clinically.
Well,
in breast cancer.
We'll ask the question a different way, is that in which way does this particular workout at the moment gives you more information than if you just look at these two markers?
Well, this is something we don't know yet. You know, folks like Adrian Lee, who's an expert in breast cancer biology, you know, these things need to be studied. And part of the thing that I think is a huge challenge for studying these things is clinically we don't really provide very much information because we have, yes, Lance?
Let me give my answer.
Okay.
And that is, first of all, heterogeneity between patients is not that old in terms of solid tumors. Intra-tumor heterogeneity is even more recent. And now we also know it isn't just the cancer cells that are critical, the stromal cells, immune cell infiltration. So if you have multiple biomarkers, cancer cell biomarkers, stromal cell biomarkers, and immune biomarkers, you're going to learn the patterns.
Right.
So it's not a diagnostic test today, it's projected, I think, that if you understand those spatial statistics, it will become a biomarker in and of itself. But I think the PMI maps that you showed, the other thing is there are now tools. One of the groups we work with is GE, where you can look at 60 biomarkers and then down select through a retrospective what are the top N biomarkers that you should quantify the true diagnostic test. So the good news and the bad news is that it's early on and patients aren't being helped with this approach yet. The good news is we're early in the game, so hopefully there's an impact factor.
And these tools will enable this. And these are things that we haven't been able to get to because we've been working on just the bare basics. We do have, you know, other markers we do. You know, if something turns out to be ER, PR, HER2 negative, we have additional markers we use. Androgen receptor, or other markers, cytokeratin 5, trying to decide if it's a basal-like phenotype, staining pattern. But yet, like what Lance said, I think this is really neat because we are beginning to be able to have these sort of tools so we can begin to make these assessments of the tumor that wouldn't have been possible on the glass slide. It really, how do you do that? Circle the tumor, you know, there's not really a scheme, a manual scheme that lets you articulate intratumoral heterogeneity or do anything beyond really rough, like just throwing a couple of stains, ER and PR and HER2 and giving gross statements of the pattern without delving into the actual inside the tumor pattern. Thank you.
With that, thank you.
Thanks for coming.